Thank you for coming today.
Yes, thank you. Lydia, are you able to go up top and change your name? Do you know how to do that? It's at the little, if you click on your camera.
Yep.
And then the little dots.
Yeah. Let's see. Yep.
Thank you.
Yep.
Beautiful.
Now I'm me again.
Yes.
I think we're ready to get started. Hi, everyone, and welcome to the third day of the Global Health Career Pathways Week. Throughout the week, we'll be having different speakers from the field speaking from 12 to 1 p.m. Today, we have with us Dr. Lydia Ogden, who will be speaking about some of her experiences in global health. The presentation will last around 50 minutes, and we'll leave some time at the end for Q&A. With that, I'd like to introduce Dr. Lydia Ogden. Dr. Ogden leads All Access Health, which is focused on forging successful public-private nonprofit partnerships for global health. She's an adjunct fellow at Penn's Center for Public Health Initiatives and teaches a course on global health security in the MPH program. Dr. Ogden joined Merck in 2012, directing US and international work in vaccine policy, partnerships, and government relations to globalize Merck's vaccine business and improve immunization rates worldwide. From 2017 to 2019, she led company-wide strategic engagement with international organizations, foundations, institutions, and industry associations, spearheaded the overall access efforts, and served as the public policy lead for the company's Public Policy and Responsibility Council. Before joining Merck, Dr. Ogden worked in public health for more than 20 years at the CDC, leading domestic and international HIV/AIDS policy and data-driven prevention programs, implementing PEPFAR, serving as the agency's Deputy Chief of Staff for Policy, and heading the Office of Health Reform following passage of the Affordable Care Act. Dr. Ogden, thank you so much for joining us today.
You bet. I'm really glad to be here. Can everybody see my screen? Great. So I'm going to apologize. There's someone hammering directly below my feet. So we'll just have to get used to those little punctuation marks. So really what I would love for us to do is spend, since there aren't a huge number of people on the call, could we just kind of spend a little bit of time with you guys giving me a little synopsis of who you are and where you are in your program and kind of what you think you want to do when you're done? That would be really helpful for me to be sure to tailor what I offer to you today to sort of meet you where you are. Would that be all right? Good. So, yeah. So I see, everybody at this point. I'm just going to call on you in random order, if that's okay. Margot.
Hi, everyone. I'm Margot. I am in the MPH program. And I am planning on graduating in May, so exciting, and still trying to figure out what I'm doing after graduation. I was a Peace Corps volunteer in Botswana, and then I started the Penn program, and while I've been at Penn, I've worked with healthcare reform organization as well as a more local organization called Camden Coalition, doing some work on maternal health and substance use programs and complex care curriculum development. And so in the future, I think I'd like to do something with like program management and like curriculum development and kind of like building or creating materials to help people build the skills. And looking to that either domestically or globally.
Good, thank you. I'm just going to continue down the pathway. Is it Alejo?
Yes. How is everyone doing today? Yeah, so my name is Alejo Carvajal. I work here at the Center for Global Health. I have completed my MPH in epidemiology and a sub-focus in global health. Some of my background, I did my practicum with ICAP in Lesotho, where I worked on an HIV and TB retention program, specifically with mine workers and their family members, as that's a a large population within Lesotho and very transient, and so difficult to connect to care and to keep individuals in care. Yeah, it's a pleasure, and I look forward to hearing your talk.
You bet. Thank you. And I know that program well from my PEPFAR days. So that's great. Nice to have that connection. Lynn.
Hi everyone. Actually, I am from Vietnam and I am just an undergraduate medical student. I'm a freshman here in Vinh University. And if you don't know Vinh University, it's a college that University of Pennsylvania partnered to build, and our university is only 2 years old. I am really lucky today to access this webinar, this symposium, to learn more about public health, because I personally really care for global health in terms of nutrition. And thank you for having me.
Absolutely. Welcome. Thank you for joining us. Amy.
Hello, good afternoon. My name is Amy. I am a first year MPH student, but second semester. And right now my interests are really based in human rights, policy, and refugee health.
Okay, good. Thank you. I've been doing some work with the humanitarian buffer with COVAX as part of my work with J&J, so we can come back to that. Maria.
Sorry. Hello. My name is Maria Cortese Herring. I did my MPH at Penn in the Global Health track, but I currently work as the Assistant Director for Global Health Training here at Penn in the Center for Global Health. So I like to work with all the students here to help them with any sort of global health experiences they may be interested in. I look forward to hearing you speak.
Great, thank you. Megan.
Hi, I'm also in the Center for Global Health. I'm the Director of Operations and Programming and have been in the field for about 20 years, starting with Peace Corps in Mali. And also look very forward to hearing you. So thank you very much, and would love to meet with you after.
Okay, super.
I'll reach out.
Yeah. I was on campus, obviously, when I was teaching my course, but I'm a stone's throw away. We're just in West Mount Airy. So
Oh, perfect. Okay.
yeah, and I have a kid at Penn, so I'm always looking for any excuse to embarrass him by showing up randomly.
All right, I'll give you that excuse. Thank
Thanks. Anisha.
Hi, my name is Anisha. I'm a second year MPH student also on the global health track. My interests lie sort of at the intersection of global health, economics, and development. So I've been working on different projects at Penn Center for Health Incentives and Behavioral Economics, with a chance to potentially continue that work after I graduate and possibly go to Kenya over the summer, which would be definitely exciting to be in the field.
Yeah, that's great. Fantastic. Well, we share that intersectionality of interest, so hopefully that'll come through in what I talk about. I encourage you to push me on those points. Carolyn.
Hi, everyone. I'm Caroline. I'm graduating in May, and previously I was a Peace Corps volunteer in Ghana. After graduating, I'll work as a quantitative analyst at the VA and hope to transfer to USAID or CDC in a program management capacity.
That's great. Exciting. And last but not least, my alter ego, Miranda.
Hi, I'm Miranda. I am on the global health track and also graduating in May, many of my classmates. I am currently in the job market looking mostly at global nonprofits and trying to get into like the global reproductive health space. I was also a Peace Corps volunteer in
Yeah, we have a real plethora of RPCVs, so that's great. That field experience is really important. So, okay, so I would really love for this to be a discussion and not a speech or a lecture. So I do have just a few slides to sort of kind of give you guys a contour of my career in public health, which is now more than 3 decades in the making. And so there's a lot of territory to cover, but I'll try to hit the high points. But it would love for you all to just, interrupt and ask questions, including, why did you do that? Or what were you thinking? Or, who said that that was a good idea? Really would love for this to be more interactive, and we'll try to keep us on time and get you out of here on time. So if that's okay, I will. So I know that you guys heard my bio at the top, but what I wanted to do is sort of give you an idea of how many different things I've done. And, to the degree that one of my children, when he was much younger, said to another relative, my mom just can't keep a job. And it's because I just sort of flitted around and did whatever I thought was interesting, and said yes a lot. So just a quick overview. I started my professional career when I started at the bottom. I was a school teacher. I taught 5th grade gifted kids, and then I taught, I was sort of an itinerant sub, and never knew on any given day where I was going to go. I taught 8th grade grammar and composition, which my students from last term probably suffered from. But if you can teach 8th grade boys to diagram a sentence, I think you can do almost anything on the planet. Oh, looks like we have someone joining. Let's pause for a second. Olivia, welcome.
Thank you.
Everybody else had a chance to sort of give me an idea of what their interests are and what they're doing. Do you want to, I hate to put you on the spot, but do you want to just take a sec to do that?
Sure. So I am a second year in the Masters of Public Health program on the Global Health track, and I'm interested in a variety of topics, but mainly like maternal health, refugee health, communicable and non-communicable diseases, along those lines.
Okay, super. Thank you. Well, welcome. I'm glad you could join us. I'm just kind of going through my checkered career, and then we'll talk about how I got to where I got to. So taught school, as I was saying, I taught 5th grade gifted, I taught 8th grade grammar and composition, and then sort of just became a permanent substitute. And the interesting part about that is that I was substituting in the school system that I had graduated from in Middle Tennessee. So it was very weird to go back as a peer, to some of the people who had taught me, civics or whatever. So it was an interesting year and a half or so until I decided that I really did want to go ahead and get my master's degree. So we'll come back to that. I graduated with a master's degree and then became a healthcare reporter and editor for what was then known as Medical Economics. And they had a newsletter, a monthly newsletter series of publications. So the first newsletter that I worked on was called Hospital Risk Management, and it's about what it sounds like. It was telling hospitals and physicians how to keep from getting sued. And, did a variety of other newsletters, from same-day surgery to contraceptive technology update to just a variety of different things. I went to DC for a while and then all of this was happening in Atlanta. And then I came back to Atlanta. I worked in a public relations and marketing firm, and then quit that to run a soup kitchen. And because I'd gotten to know a guy who lived in the doorway of our building, and I would bring him food from home, and I would said, what do you do when I'm traveling? And he said, oh, I go to this great place right down the road called Cafe 458. And you go in and you sit down at a table, and you order from a menu. And I was like, wow, this is amazing. Like, I had never heard of anything like that. I'd worked in soup kitchens before, but they were standard soup line soup kitchens. And so I quit my job and went to work for that soup kitchen. And finally, actually, my dad said, you're going to be one of your own clients, and unless you actually get a job. So I needed a job, and I took a job on at CDC, actually just as a consultant. And that job was writing a report on medical waste for Congress. Let's see, we've had Catherine join us. Hi, Catherine, welcome. Do you want to take a second to say who you are and what you're doing here?
Oh, sorry, my name's actually Elizabeth.
I thought it was. I was like, that looks like Elizabeth.
Yeah, I'm using the Zoom link. And I think
Okay.
I need to edit it. But yeah, my name's Elizabeth. Sorry, I'm a little late. I'm just excited to hear about your talk.
Yeah. Okay. Welcome. I was like that, the little postage stamps. I was like, that looks kind of like Liz, but I don't want to like, okay. So, that was my first job at CDC. That was in 1989. And I was hired into the part of CDC that hired me to do that report to be a medical writer at ATSDR, the Agency for Toxic Diseases and Agency for Toxic Substances and Disease Registry. And after about, I don't know, 6 months, 9 months of doing that writing job, what I said to the guy who was running the agency, who's working with the communities who are living around these toxic waste sites? Because, they're pretty traumatized by the time ATSDR gets there. EPA has been there, and they've, frequently closed off large parts of town, or they've said, your kids can't go on the playground anymore. And, these are complicated issues. And they kind of said, well, nobody's doing that. Why don't you do it? So that's how I became essentially a community organizer on the government's dime, and devised a community engagement program for ATSDR that was designed to give people agency and decisions that were affecting their lives. And you can't just do that and say, here's a chemical compound that is, 37 characters long and just figure it out. It really becomes education and support services and, kind of like a whole little wraparound program. And about 2 years or 3 years into that was concurrent with the time that ACT UP was having die-ins in front of CDC and NIH, and throwing not real blood, but throwing fake blood on CDC scientists and NIH scientists at podia. And the HIV program called and said, we've heard you've done this really good job with toxic waste communities. Can you do the same thing with ACT UP? And I said, sure. So that's how I went over to domestic HIV and devised a program called the Prevention Collaborative, which was designed to bring voices into the agency, ranging from not just ACT UP, but other, non-governmental organizations, community service organizations, all the way over to the very other side of the spectrum with groups like the Moral Majority and Families First and Focus on the Family, because everybody had an opinion about HIV and what needed to be done to do HIV prevention, care, and treatment. And people were often talking past each other. And, the purpose of that Prevention Collaborative was to try to find common ground. And so did that for a while, and then moved into international HIV, around the same time that the president's emergency plan for AIDS relief hit. There was a little blip in between there that I'm going to come back to. And very quickly after that, sort of just things took off. PEPFAR was a very, very intense experience. Nobody quite knew what had happened when we got all of that money. And we were working with countries that many of you have just talked about in terms of your Peace Corps service and the infrastructure at that time. So this would have been like 2002, 2003, was very limited. And so we had to figure out how to, not just infuse cash, because that wouldn't be successful, but to work across, very similar to the Prevention Collaborative, work across governments, work across NGOs, work across civil society to develop comprehensive prevention, care, and treatment programs for people living with and at risk for HIV. Fast forward, I went away for a PhD. I'll come back to that. And when I came back to CDC in 2010, I was tapped to lead the Office of Health Reform after the Affordable Care Act. But in between doing that, I was asked by the White House to serve as the Chief Health Advisor to the National Commission for Fiscal Responsibility and Reform, which was a President Obama initiative to look at the major sources of health spending, or not just health spending, government spending, of which health is a significant factor, and how in my particular area, how we could reduce the rate of rise in that spending, but still maintain quality and still maintain access for people. So that's a tricky triangulation to work. And it was particularly tricky because ACA had just passed and nobody wanted to relitigate ACA. So did that for a while, then came back to CDC, and in late 2012 was asked by the former CDC director to come to Merck to globalize Merck's vaccines business. And so I did that for 5 years, and then stepped into a larger role at the company to devise a strategy for Merck's multilateral organization engagement. So WHO, the World Intellectual Property Organization, the Gates Foundation, Wellcome Trust, et cetera, et cetera. And as part of that remit included global health security, which is why I ended up teaching the course at Penn, and as well as Merck's portfolio-wide access strategy. And I left Merck in mid-2019 and just ahead of the pandemic, and honestly have been just super busy since the pandemic started, because there are just a very few people who have kind of worked both sides of the aisle, if you will, which I did throughout my policy career, but also both sides of the public-private sector kind of continuum. And so I say that not that I'm, so special, but because I just kept saying yes at all these different points in my career, I had a very diverse set of experiences and a very diverse set of knowledge and skills that all of a sudden were in really high demand. So the takeaway here is say yes, and I'll come back to that. So I said I wanted this to be a dialogue. So any questions or comments, or like, what were you thinking type responses before I go on? Okay. So here's the question. How does somebody with a BS in English and education with minors in philosophy and history, and then a master's degree in Anglo-Saxon and early English literature, right? So like Grendel and The Dream of the Rood and stuff like that. How does somebody like that end up in public health? All I can tell you is that equity and inequity have been at the root of whatever I've done kind of over the course of my career. And public health was such a crucible for those issues that when ATSDR, initially came knocking about this, honestly speaking, I wasn't like super excited about doing a report to Congress on medical waste in the environment. But as I got to know what the agency did and saw how critically important it was to people who are largely marginalized in the United States of America. They don't put toxic waste sites in rich communities. And I just became incredibly animated by the possibility that I could do something that would be incredibly impactful for those communities. And that's just sort of been my philosophy all along. And as I just sketched out for you, when people see you say yes, and people see you leaning in and doing your best to craft a better solution and a non-conflict ridden solution, then they want more of that. And so what happened after that was CDC was conducting an anonymous survey of dried blood spots from neonates, right? And by anonymous, I mean that these heel sticks are done for every kid, or most every kid born in the country, and they're associated to the delivering mother. But you can just cut those spots off and test them later for HIV, which is what CDC and state health departments were doing. And it was a way of tracking how how HIV was moving through the female population in the United States. And it was an incredibly useful survey from that perspective, because initially it was, a few women here and there, and it quickly, as you all probably know, began to move very, very quickly through women, chiefly women who were injecting drugs or women who were doing sex work. So by tracking that was an important input to what kind of services those women needed. But what happens is that a couple of politicians in New York, where the problem was most severe at the time, heard that this was happening, and their soundbite was, CDC and the state health department are testing babies and sending them home to die. So that wasn't true, because there was no way to track those babies. These were anonymous heel sticks, right? But there's really no way to win that political argument, right? And there were calls in Congress for CDC's funding to be taken away, and calls at the same time in some state legislatures to make HIV testing for pregnant women a mandatory service, I'll say, in quotes. And because the presumption was that if they were tested and if they were found positive, then what? I don't know, they're going to strap them down and make them take ACT. But, it was a year of really, really, really difficult kind of, in the true political sense, hand-to-hand combat in state legislatures and in Congress. And I remember vividly, standing with the head of HIV at that time, Jim Curran, and saying, there has got to be a better way to do this. Like, we are our own worst enemies. Our scientists were publishing reports about infants not being diagnosed with HIV until they were diagnosed with PCP. And at the same time, we were prosecuting this survey, and we didn't connect our dots internally, right? We can't keep doing this because it's not explicable to the American people. And by the way, they are the ones who write our checks. And so he said, well, yeah, you're right. So if you can figure out somewhere to go get trained, go do that. So that's how I ended up at Harvard at the Kennedy School in an MPP program. And it was truly a life-changing experience for me, because the policy work that I had done up to that point had been just kind of flying by the seat of my pants. And I learned that there was actually a structure to policy work, and that political science is maybe not a science, but it's actually a useful construct to be able to think about things. And so then I came back to CDC with that MPP and was at that point tasked with developing CDC's first ever strategic plan for HIV prevention. And it's hard to believe that in all of those years and millions of dollars that Congress had given us, that CDC had never had a plan. But in the wake of the survey of childbearing women, and in the wake of CDC going to the well over and over and over again saying, yeah, well, you've given us all that money, but then the numbers are still rising, and Congress saying, wait a minute, that doesn't make any sense. But we're giving you money to prevent this. Why isn't it happening? So anyway, ended up doing that. And as a result of that, that's when I got pulled up into the office of the director to sort of act as a deputy chief of staff for policy, because CDC really didn't have that either. And at the same time, there was a woman there who was one of the senior leaders who was saying, you know, where people get care is not in county health departments. It was at one time. Like if you wanted an STD test, you had to go to the county health department. And when I started at CDC in 1989, that was true for a lot of jurisdictions and things like that, right? Vaccinations. But over time, that really started to change. And CDC hadn't quite figured out that if it wanted to do good prevention, it was going to have to partner with the healthcare, you know, monolith in this country, right? That people don't go to the county health department to get preventive services or wellness care or anything like that. They're going to a clinic or they're going to their doctor's office. So this woman named Kathy Cahill said, you know, CDC is an agency of physicians and some nurses. And despite that, we don't understand how healthcare is delivered in this country. We don't know how it's paid for in this country. And we need you to go off and get a PhD and in that. I was like, yeah, no, because I have 2 teenagers and I have 2 children under 5. So that's not happening. And but she was very persuasive, and anytime she would see me in the hallway, she would like yell at me. And finally, honestly, guys, I just applied to the program at Emory because it was literally across the street. And I had no expectation that I would get in, because I said, I'm not taking the GRE again. I've done that once. And then they offered me a free ride, so I couldn't say no to that. So I did this PhD in health policy, health economics, and political science. And it, you know, was very, very deliberately a multidisciplinary program. And I think that multidisciplinary aspect of it was incredibly useful to me because, you know, that's what propelled me into the White House. That's what propelled me into going back to CDC and saying, you know, there's a difference between Medicare and Medicaid, y'all. And some parts of CDC work with one of those groups and some parts of CDC work with another, but you've got to get this figured out. So, you know, I spent a lot of time after coming back, you know, really doing a lot of just fundamental education about the US healthcare system at CDC. And, you know, it was really kind of shocking in retrospect how naive I was when I joined CDC about how care works, and certainly about how the private sector works. But without the private sector, there would be no vaccines. There would be no drugs to give to people who need them. So, you know, that's kind of a segue to my time at Merck. It was a very difficult decision for me to leave CDC. But if anybody was going to kind of persuade me to do it, it would be Julie Gerberding, because what she dangled in front of me was, how would you like to eliminate cervical cancer worldwide? Because Merck has an HPV vaccine that's highly effective. And for a public health person, you know, how can you say no to that, right? It's a devastating disease, and women in LMICs do not have the same level of care or access to care that women here in the US or in other developed countries have in terms of annual PAPs and early interventions and, you know, advanced oncology care. And so women are dying of a preventable disease in truly horrific ways in low income countries. And so again, coming back to that issue of equity and inequity, that was the motivating factor to me to say yes, because I never thought of myself as anything other than a public servant. So it was really hard to think about going into the private sector. But what I found when I got there is that there were a lot of people who were really passionate about what Merck vaccines would be able to do, not only with that vaccine, but with childhood vaccines as well as other adult vaccines. And they were doing public health, but just from a different seat at the table. So that's kind of it in a nutshell. And I have one more slide. This is sort of where CDC sits, and this is where I started, ATSDR. But the reason I put this up is because over the course of my career, I had to learn to work with people in all of these other boxes, and they are culturally really different. You know, FDA is very different from CDC, is very different from HRSA, is CMS, NIH. So, you know, I know you guys are at the doorstep of thinking about where you want to go, and for people in public health, I think CDC is and or USAID are often the very first things that people think about. But what I would say is there's really good stuff going on in the other boxes. So don't limit yourself to CDC. You know, ATSDR is small but mighty, and they're still doing really great work with communities that, you know, really need help. Obviously, CMS is at a remove from actual service delivery, but as the payer, they have an incredible impact on what services get delivered to what people and where they get delivered and how they get delivered. So that's just a plug for thinking about the other boxes. And then this is, my students have seen this slide before, but for those of you who haven't, government public health activities up here, that's 2 cents out of every dollar. So this is the plug for the things that aren't in the boxes in HHS, which is, you know, oftentimes if you want to make a really big difference in people's health and well-being, in prevention, certainly, you need to look at these other parts of the pie to think about how, you know, you might be able to make a difference that could end up being very profound, right? I mean, this was what was in the back of my head when the White House called Tom Frieden and said, we want her to come up and work on the deficit commission. And honestly, his first response was no, she just got back. And like, you just don't say that to the White House. So, you know, I ended up but this is why, you know, and it's why when I did come back to CDC, I worked in the Office of Prevention through Healthcare. And then after ACA passed, I worked leading the Office of Health Reform, because this is where people are getting touched, for better or for worse, right? So, so here's my little observations. You've heard it, say yes to anything, even if something doesn't sound all that exciting. It will be an experience that you will take forward and will inform the rest of your work. Embrace uncertainty. There were so many times when people asked me to do something and that little voice inside my head said, you don't know anything about this. But I was like, okay, I'll try it, you know. And I think particularly what I would say, I hope without sounding patronizing, but my students know that I have 4 kids ranging in age from 38 to 20. And particularly, you know, with the 2 younger kids, what I have seen is less and less willingness to embrace uncertainty, because they were told from, you know, the time they were little, prepare for whatever you're doing next, and you have to have a plan for everything and blah, blah, blah. And that is utterly antithetical to the way I experienced my career. And so I would just encourage you to take those risks. This next one's a little bit cheeky. A job description is a set of suggestions, but I've kind of made up each job I had as I went along, and ended up doing a lot of stuff that wasn't in the job description, but stuff that needed to get done. So, you know, certainly do the stuff that's in the job description, because that's what you're going to get assessed on, but then look for things that maybe are a little bit outside that comfort zone. Practically, you got to manage up, you got to manage your boss. But really where I got the most bang for my buck was in managing sideways with my peers. Because particularly earlier in your career, at least I had no line authority over anyone. So if I was going to get stuff done, it had to be because I had built goodwill and peer relationships that I could call somebody up and say, you know, I don't know how to, draft a communications plan for ACT UP. What do you think? Can you help me with that? Right. So that's important. And, then eventually when you rise to the top, you will be managing down, and that's an equally important skill. Important, I hope, as you've heard me say, to broaden your horizons. And, nobody thought my Anglo-Saxon degree was going to be of any use whatsoever, mostly my parents. But what it did teach me to do was be disciplined and to think and to try to figure stuff out, because Anglo-Saxon is not the easiest language in the world. And those are skills that did translate, right? And I will say that when my husband and I went to Iceland, I guess about 5 years ago now, I was able to read all the road signs thanks to my Anglo-Saxon degree, and many of the museum, little descriptions, and be a dot connector. I think one of the things that has been true across the course of my career is being able to take that step back and say, as I said to Jim Curran, our own scientists are at odds with each other. How come this group wasn't talking to this group? Or when I was, early on in the PEPFAR days, and I said, how come, I brought in the malaria people, and I said, how come when people are getting a bed net, you're not testing them? And they're like, well, that's not our program. Like, well, yes, but this person is showing up needing a bed net. And if they need a bed net, they might need an HIV test. So, I think it's very easy in the public health world to get very siloed. Money comes to programs in a siloed way. You're not encouraged to think across programs, but that thinking across is probably the most valuable skill. It's certainly the most valuable skill that over the course of my career that my senior leaders said to me is not thinking vertically, but thinking horizontally. So that's that. And I think I hit my mark exactly. So we've got 15 minutes for Q&A. Thank you. Thanks, Miranda. Thank you, Margot. Thank you, everybody. Seriously, you must have questions.
I have one quick question, just about your experience and overall at all of your in your different kinds of work, how it was like kind of being a woman in this space, and if you had any advice to young females that are going into the space or that identify as females.
Yeah. So I would say it changed dramatically over the course of my career. When I first started at ATSDR, so this would have been 1989, I was much younger and didn't have public health credentials, right? And I think a lot of people took me for granted, and particularly some of the older men, one of whom actually decided that it was okay to comment on my breasts, right? Or another, a board of scientific counselor member who decided it was okay for him to put his hand on my leg in a cab. And I was so taken aback and so appalled by both of those instances. But in both instances, I went to the head of the agency and said, look, this is what happened, and this is not okay. And that was a very, very scary thing to do. But, that kind of stuff, I hope doesn't happen. Maybe not never, but not happen as often as it did. And I think now the slights and the disrespect are more subtle. It doesn't mean that it doesn't exist, right? And I think what is true also, this was not as true at CDC, but probably is true in other environments, is that women who take time off to have a baby can find themselves sidelined, at least for a while. And that never happened to me at CDC. When I came back after my kids, I was thrown right back into the mix. So that's just another challenge, I think, that I hope is becoming less challenging. I do see more and more of my younger male colleagues taking, parental leave, family leave. And so it's not just left, like it used to be back when my kids came along, that it was typically seen as the province of women. But I will say this, I had a partner who we met at CDC, and I could not have done anything that I did with my career without his complete and total support. So I was very lucky in that way. And that some of my students have actually met him because he came to lecture in the class one day. So other questions?
I kind of had a question to build off that. First off, thank you for coming to speak to us. It was also really nice to hear like such a big breadth of your experience. I feel like we got bits and pieces of it in class, and like kind of the timeline. But my question is, like, when you say yes, and like kind of maybe, like you said, you didn't have as much like public health experience and people took it for granted. What are like some tips, or do you have any insight on kind of overcoming the imposter syndrome, especially like we're kind of entering the field right after this program, and some of us have different like varying levels of experience. Do you have any insight on that?
Well, look, it's real, right? And I think for me, there were different times over the course of my career when that felt more paralyzing than it. I think when I was younger, I didn't know what I didn't know. So I was just like charging right in there. And it wasn't until later that I thought, wow, what was I thinking? But the most important thing I would say is having, an incredibly solid peer group. And so one of the things that I did when I was hiring new people at Merck, who were coming from outside that Merck experience, right, was to make sure that they were set up with a peer buddy that wasn't part of our group, but could, that they could go to say, why in the world do we do it this way, and get an honest answer. And I also set them up with a more senior person who could be a sponsor and a mentor, again, outside of our group. And I think it's important to seek those things out if your supervisor or others aren't offering them to you. And maybe even to start a program like that, right? Because it's very hard to go into a new environment, even if it's a very welcoming environment, because there's so much that you don't know. And as we talked about in class, culture eats strategy for lunch. And so you have to learn that culture. And sometimes you just need somebody to explain it to you because it just seems nutty.
Thank you.
Mm-hmm. Anybody else?
I have a question.
Mm-hmm.
I was wondering if you could speak a little bit about and provide advice regarding regarding advice about someone who's torn between whether they should do private or public work.
So I was torn, as I shared with you all, and because so much of my identity was wrapped up in the fact that I was doing public service to the people of America, or more broadly in PEPFAR. And so I think the fallback is what I said a little bit ago, which is any experience that you have becomes part of, your inner tapestry. And you know, not that no experience is you know, bad. Some can be very bad, but I think you know, knowing that if you, let's say, if you take a job in the public or private sector, let's say, for, it's not forever, and that knowledge that you're bringing from the private sector, if you go then to the public sector, is invaluable, because there is so little crosstalk. And we see that now in terms of people, you know, very specific examples in COVID where people are saying, well, why couldn't we just make enough vaccines for everybody on the planet in 3 months? Well, you can't do that, because that's not how manufacturing vaccines worked. Even if you threw all the money in the world at it, vaccines are really hard to make, and just yelling at the production line won't make it go faster. So, you know, those kind of you know, crosstalk experiences, and being able to bring that experience from the public sector to the private, or from the private to the public, or not for profit, I think those are all really valuable. So, you know, from the nonprofit perspective, there was nobody else at CDC who'd ever run a soup kitchen and dealt with addicts on a daily basis, right? So that when I was then in HIV, and they were saying, well, we're going to do this program or that program, I was like, hold on a minute. Let me tell you about my guys at the soup kitchen, because that's not going to work, right? And so I just think that all of those experiences are useful, and nothing is forever. And if you find yourself in the private sector and you're miserable, then say, okay, I'm going to give this a year, and maybe it'll get better. And if it doesn't get better, I'll go do something else. But I think for that can be a scary thing, right? Because you guys have had your entire existences planned out. That's why you're at Penn. And so that's what I mean about embracing uncertainty, right? So I will share with you some news. I have, despite some misgivings, accepted a role at J&J, a full-time role. I'll be leading global public health R&D policy and engagement. So working with the G7, working with WHO, et cetera, you know, on R&D for specifically for low-income countries. So I'm excited about that, but I really wasn't sure I wanted another full-time job at this point. But it just seemed like such a great opportunity, again, around the equity issues. So I said yes. All right, I think we're just around at time. If final call for questions. All right, well, what a treat to spend some time with all of you all, especially those of you who are in my class whom I've missed, and keep in touch.
Thank you so much.
Yeah,
Thank you.
absolutely. Talk to you soon. Bye.
Bye.